Hello, folks on Zoom. Thank you for getting up early to join us. We have a number of questions, so I'm going to go through, and we'll open them up to whoever wants to respond, and we encourage everybody to respond if you can. So first question's on immunity. The T cell work is interesting. The immune system is complex with many differences between species. Care to comment on variations and potential applications based on that variability? Dr. Drescher, or did you hear? Did you hear?
Repeat, please.
Okay. So the T cell work is interesting. So this may be to both of you. The immune system is complex with many differences between species. Do you think that might be part of the reason we're seeing differences? And what do we need to think about in the future about how to do the work in this area?
When you look at sort of the neurodegeneration experiments that have been done in mice, I think the biggest issue is when you look at the dose given to mice of creatine versus the dose given in human trials, which is much less than what you see in mice. And, if I had a family member who had, Parkinson's disease or traumatic brain injury, I think that something like gastrointestinal distress is a small price to pay for an improved brain function.
And I was also struck when you were doing your talk about the gut-brain relationship. Do you think probiotics may have a role in enhancing the efficacy of creatine?
Yes, I think one thing that's been ignored, creatine is safe. We all know that. But oftentimes people who take creatine are taking multiple different supplements, and we haven't really examined the impact of those supplements on, there's a whole lot of things that can happen in terms of interactions, and we don't want creatine to be, shall we say, having a bad reputation because of other things that have happened, that other things people are taking.
Okay, great. So follow up to that for Dr. Yang. You showed that tumor-induced T cell function can be affected, right? Do you think that there's a potential for creatine supplementation as a prophylactic, preventive aspect to delaying the impact on cancer or slowing down the potential realization of cancer?
Yeah, Rick, thank you for the question. So the study we have been doing is currently preclinical, but in the animal model, like we tried both the prophylactic treatment versus the therapeutic treatment, and the creatine supplementation in these models work for both. So like for the preventive application, like if we give the animal a creatine supplement prior to tumor challenge, it indeed helps to slow down the tumor growth or prevent the tumor growth. And for the therapeutical treatment condition, we tried the creatine supplementation alone or in combination with the immune checkpoint blockade therapy, like anti-PD-1 therapy. We find that the creatine treatment alone, can help, for the immune cells to fight off tumor. It also, can synergize with the immune checkpoint treatment to slow down the tumor growth even better. In some conditions, it helps to eradicate the tumor, and only the combination of those really can achieve that. So based on the science behind this, like creatine can help boost the T cell energy, right? It works like a energy buffer help T cell to sustain better and fight longer. So seems that it really can benefit the anti-tumor immunity side, both prophylactic and treatment-wise.
Well, I've got to add that I've known Dr. Stout for a long time. He's sitting a few rows ahead of me, and after your talk was finished, he turned around and mouthed, "Wow." Pretty great stuff, so very good, congratulations. Okay, I have a question about creatine synthesis deficiencies. And we have Dr. Braissant with us as well. And so the question from the audience is, if I can find it, can we expect similar symptoms if people are consistently consuming too much creatine? Is that the question? No. Oh, if they're consistently too low, do we expect different results?
So, do you hear me?
Yeah. So the question is, if we have certain symptoms and creatine deficiency, and now if we have someone who really doesn't have 100% deficiency, but is consistently too low, can we expect to see similar system? Of course, not to the same extent, but as a tendency for those people. Okay, clarified, thank you. So the question is, we know there are certain effects in patients with creatine synthesis deficiencies that can help more normalize their outcomes. If you have people who are low on creatine, would you expect also a improvement to some degree, maybe not as much, in people who are just low dietary availability of creatine that may not be deficient but aren't producing much or having a high level in the brain? So that's... Dr. Braissant, do you want to answer?
Yes. Well, in people who consume less creatine, in principle, you have an upregulation of the creatine synthesis pathway, especially on the AGAT gene, and so they should be able to maintain sufficient amount of creatine, especially in the brain, as we have demonstrated that there is an internal synthetic pathway within the brain. So they should not be creatine deficient. So in these people who do not have a creatine deficiency, as the one that Pauline presented, they should not be creatine deficient, especially in the brain.
Okay.
Due to this upregulation.
So part of the question is that there have been epidemiological studies, particularly in women and others, that have low dietary availability of creatine, less than we probably all thought, maybe half a gram or so in the diet. And we know they're chronically low in muscle tissue, for example.
Yeah.
Would you expect maybe some cognitive benefit as well, even though they have the ability to synthesize, or do you think there's just enough to do what they need to do?
Well, they may benefit from creatine supplementation, of course, but especially within the brain, there should be an upregulation of the creatine synthetic pathway, and they should not be brain creatine deficient.
Okay, so another question came in, several, on the thermogenesis talk Dr. Uwe Schlattner did. So one of the questions is, would exercise that is thermogenic in itself and increases ATP production, would that maybe cause an additional additive effect in the potential futile cycle thermogenesis you mentioned?
Well, exercise will, of course, add part of thermogenesis. It is not considered as adaptive. Adaptive is really the response to cold or diet. Of course, if you are cold and in a cold environment and you use exercise, and that is, of course, can be also supported by creatine, that will generate heat. But that's another kind of thermogenesis.
So, but the question would be, would there be additive potential?
Yeah, of course.
So we're actually doing a study now on weight loss with creatine to try to keep muscle, lose more fat with exercise. And we're doing energy expenditure studies. I'm hoping we find some kind of interesting dynamic there. So very good. Another question would be, is more creatine better for thermogenic effect?
Yeah, that's a big question. As I showed you, the only study existing, they improved creatine levels a bit by their regime. I think that were 9 days supplementation with 20 grams a day. Didn't show significant effects. Okay, so now one can ask, okay, if you take creatine long term and if you go for, cold exposure, that is a bit more stringent because there the patients or the province were just exposed for a session to a temperature a little bit above the shivering threshold for half an hour or so. And as we all know, creatine kinase system is often a backup for really harsh situation, for extreme situation. You have to push the animals. It's typical in the knockouts, for exercise protocols. You have to push them to limits. And I think this wasn't done in that study in respect to cold.
Okay, thank you. Another question I have for Diego. How will AI change or enhance the bioinformatics gathering and connection of networks that might have some interplay in how would you then translate that to the actual researcher?
Okay, I guess that actually is taking place now in exercise sciences, but in basic science and some other fields. Bioinformatics and models and modeling has been used quite a long time, and it has helped a lot to make the designs better, to even have some better disposal of the resources that we use. So I was mentioning to Dr. Stauda and Dr. Eric Braissant just recently that, for example, for the exercise immunology, Dr. David Niemann has been encouraging people also to deep more in bioinformatics, to also start using some of these predictive and current data that exist to enrich the topics. And I want to mention something that just remind me with making some links between the Dr. Drescher's talk and the sarcopenia thing. And is that we recently talked in one meeting of the sub-members about the possible potential that exists of these probiotics with creatine. And that came that the hypothesis that perhaps creatine consuming bacteria that start appearing in elderly are responsible for these also lower levels or low availability that exists in the human being. And those ideas came from bioinformatics actually, because we were doing some stuff using some species of bacteria that can also metabolize creatine. And it reminds me the paper by Dr. Marcus Wies, that classical paper of 2000, where he was also putting too much thing on the creatine and bacteria. And recently, I just have it here just to bring you the name, in December the 5th here in 2024, there was published a paper that Dr. Drescher could be also interested, because it was a supplementation with Bifidobacterium animalis. It was a probiotic that improved sarcopenia, physical performance in human beings, was done a clinical trial, by mitigating creatine restrictions. So it's very interesting because the findings, they are saying that this probiotic reduced some pathogenic gut bacteria that were perhaps consuming creatine, and because of this increase in creatine circulation, that was the association that was found with the physical performance. It was published just a couple of months ago. It's available in NPJ biofilms and microbiomes, so you can take a look. It's by Dr. Zhang and collaborators. So it brings these kind of things. And look, it was because of some of these hypothetical and predictive bacteria that were consuming creatine in the elderly. So perhaps this combination is not that wrong. So as you mentioned it, and we know that the good effects of probiotics and creatine, those could be a very interesting field of research in the upcoming trials.
Thank you very much. So a question for the folks doing the basic research in animals. How do your doses relate to human doses? And are there different doses for different cancers or different immune cell functions, et cetera, or even brain function in people with deficiencies? So Dr. Yang, different doses for different type of...
Right. So in our animal study, we try to adjust the dose in the way that when creatine levels ended up in the blood circulation to be matching the level like happening in the human while you're trying to like in the creatine like boost stage. So that's the level we're trying to match. We did find a dosing effect. If we lower that dose compared to the peak loading, like blood circulating creatine level, like we did see a reduced level, of the therapeutic effect. That can be measured by the immune cell response, like T cell activity and other immune cell activity. So indeed, like those matters in that case.
So what was the level in the blood you were trying to get to? For example, if you do 5 grams, you'll get a peak up to say 800 or so. Are you trying to be in the 300-400 range or like a 2-gram dosage? What was your dosage you're trying to maintain?
That's a good question. Sorry, I cannot remember that top of my head,
So if you go back to the 92 paper with Roger and their group, they looked at 2 grams of creatine monohydrate in a drink, 2 grams in gel, and then looked at a pound of meat that would provide about 2 grams. And they generally got about 300 to 500. And then if you gave 5 grams, they got up to 800. And so their hypothesis, you need to have several times a day to get 800 to maximize absorption. So I'm wondering if you can compare those maybe another time to what your doses are. And that might give you some inference about what the potential human dose is to get that equivalent in the blood.
Yeah, that's a very good point. Right, we not just tried the formulate creatine into the regular food, for mice, or we gave the animals through the IP injection, that's mimicry, the IV injection. But what you propose, the way of giving and the level of the dose is very interesting. We should try in the future study.
Very good. Dr. Drescher, what about your impressions on the doses you're using compared to what the human dose would need to be?
Okay, so the doses that we were going for in the mice were 20 mg per kg, so similar to a loading phase. And what we didn't anticipate was the fact that the mice really enjoyed sucrose. They just really had a sweet tooth. So we were up to, when we were measuring water and intake, was about 50 mg per kg, which is still significantly less than what a lot of the previous papers were in mice, where they were going up to 80 mg per kg per mouse per day. So I would like to see how low we can go and still get the effects that we're seeing.
Okay, and then for Dr. Braissant and Leal, a lot of the... Yes, dosages for your creatine synthesis deficiencies historically have been very high for a long time. Has that changed? Any recommendations?
In our rats, when we supplement, we put 2 grams per kilo per day in the drinking water. So it's a classical doses supplementation.
Very good, thank you. Okay, so another question we have is another related to animal versus human research. Dr. Tarnopolsky and I published a paper way back on species variations in creatine. How do you think the mouse and the rat models and others are translating to human, and what recommendations you have for the human researchers out there to interpret your data to be able to better design clinical trials? Dr. Leal, you haven't talked. Why don't you give us a shot?
Yeah, it's because I'm pretty new in the field. So as I showed in this morning, we developed a model with a mutation, really the same mutation that we are seeing in human. So, and then when we looked at all the symptoms that we see in human patients, we were able to see the same in our rats model. So, yeah, it's not a real patient, but we are able to have all the different features of the disease in our model. So I think it's kind of a good argument to say that if we are able to improve the symptoms of our rat model, we will probably be improving also the symptoms in human. There is a lot of model of the disease. There is also mice model. And for this, Olivier will be more able to talk about. But I just know that our model really has the same mutation as human. And it's making our model really good for studying the treatment, the potential treatment in the creatine transporter deficiency. But maybe, Olivier, you have something else to add? I don't know.
Yes. So since a very long time, I'm working more on the rat than on mice. As I'm working on the brain, it's easier to work on the rat. But because, of course, you have more material, it's easier to observe, etc. But more and more, the rat models of human disease are recognized as probably better than the mouse models. And for a very, very long time, people were wondering why rat models of human disease were showing better adequacy to what is observed in human. And maybe the reason is a metabolic reason. Rats are omnivorous as human, while mice are strictly vegetarians. And despite both are rodents, they diverged quite a few million years ago. And rats, and also despite they receive the same diet in the animal facilities, the same pellets, rats have probably retained in their genetic memory this omnivorous metabolic system that makes them more or nearer, let's say, as human metabolism than the mice. And for many, many diseases, rat models appear better than mouse models. But of course, for a very long time, it was not easy to produce knockout or knock-in, in our case, rat models. And it was much easier to produce the KO mice. It's due to the speed of the embryo in the trunks of the females, and the work with the very first stages of the embryos is much more difficult on the rats than on the mice. But now with the CRISPR-Cas9 technology, it's much easier, and many new models of rats are appearing for human disease.
Dr. Schlattner pulled the microphone, so he's going to comment.
I just wanted to support what just has been said. We also switched to rats for our project. And one of the reasons was also that they are somehow closer to humans. There are some differences in adipose tissue, in brown and beige adipose tissue between mice and humans, and this is less with rats. But still, there are differences, so translation will not be simple because brown adipose tissue in humans is very much reduced during evolution, and in modern humans there is a large variability. There are people that have very few brown adipose tissue and people that have quite a lot. So there's a large variability. Nobody knows exactly why. So that's of course still an additional difficulty, but red may be the better model too. Yeah.
Okay, my last question, I've been asking everybody about.
Can I
future
comment?
direction. Oh, go ahead, please.
So in general, the Food and Drug Administration, when they make a recommendation about a drug, or not necessarily, I'm not talking about creatine specifically, want to show proof of principle in 2 species lower than humans before it would go into human trials. So if we show something in mice or rats, we'd want to show it in maybe guinea pigs or gerbils or something like that.
Great point, thank you. So my last question, we've been asking everybody. What needs to be done to advance your area of creatine research? What would you like to see happen by the time we meet again in 3-5 years or so? What do you need, and what do you think needs to be done? So let me go in order of the presentation. We had the discussion with cerebral deficiencies. So what do you think needs to be done to really move this forward in the next 3 to 5 years?
Okay, I will try. Next 25 years, I don't know, but yeah, for now, as I said, I just started like in September, so I'm really new in the field. I'm discovering creatine world. But
It
yeah,
makes some of us feel old.
but for our part, maybe yeah, just for now improving our AAV model, just to have some things to give to the patients, the creatine transport deficient patient, who have nothing, no treatment currently. That could be a really good thing in the 25 years. I don't know if Olivier, you have something to add?
Yes.
No, in fact, creatine transporter deficiency is the most frequent of the 3 creatine deficiencies. And as Pauline just said, we don't have any satisfactory treatment for the moment. Creatine has been tried, creatine precursors, creatine derivatives, and nothing works. So new approaches like the one we have for gene therapy, but there are a few other ones like pharmacochaperones that are also developed in other groups to try really to get a new treatment possibilities available for these patients, which are quite frequent, as Pauline said. It's creatine transporter deficiency. It's about 1% of all the mental retardation, for example, in male patients. So really try to have a treatment possibilities for these patients.
I'm sure they're very anxious to see that happen. Dr. Yang, how about yourself? You've been working in the cancer area, and you've seen from the basic areas some very fantastic initial findings. What needs to be done next? Not only to validate the impact on cancer, but then go beyond that into public health.
Right. So like what we find about the T cells certainly go beyond the T cells. I mean, for the immune cells, like they belong to this category of cells, really like energy demanding cells, right? Like that along with the brain cell, along with the muscle cell, like they really need the energy to do their job. And immune cells certainly involving controlling cancer and many other disease situations. Right. So like, and they also contribute to the vaccination, and the other, kind of a medical treatment, like make us better and healthy. So I think in the next years, many years, I would really hope to see that the study of this aspect expand, to the broader, immune system, like certainly go beyond the T cell, maybe B cell. I mean, there's the other dendritic cells which we are currently working on. And for the medical practice, it would be very interesting to see stringently designed clinical trial being run. Really like study the possible benefit, like creating supplementation may help cancer therapy, cancer immunotherapy, may help the other type of therapy, or even the vaccination, right? So like you would imagine, like the like flu vaccine, COVID vaccine, whatever we have receiving right now. Like if you give energy boost, to the immune cells, it may help generate memory. It may help it work better. To look into those effects will be fascinating. But I think it really, for the human side, it needs some very well, designed and carried out clinical, trials to figure this out.
Thank you. Same question, Dr. Drescher, for your immune aspects. What do you think needs to be done?
Okay, so I think the next step in my work is to actually look at how the microbiome in vitro and then in vivo impacts leaky gut. And I just recently found out that, I'm saying in the last 2 weeks, there's somebody who's, 100 feet away from me who specializes in leaky gut. And so we're in talks to do some experiments in vitro, and looking at specific species of bacteria and how, in the presence or absence of creatine, you will see changes in the leakiness of the gut. And then at that point, we would like to go into germ-free mice and reconstitute them and see what's happening there.
Excellent, thank you. Dr. Schlattner, how about yourself? What would you like to see happen?
Yeah, on the topic that I presented, I think the papers that have been published triggered quite a lot of interest, and I know there are different projects going on. There is a lot of interest in this connection to obesity, so it's easy to get funded in this field. At least us, we will look with experiments in the test tube, in adipocytes, and in rats, as I mentioned, to get a hand on the mechanism. And I think in a few years we will really know how this creatine-induced thermogenesis works. And I hope that this will then also answer the question if we can interfere. If that will be only creatine supplementation, I don't know. Maybe we need another trigger, but that's pure speculation. But for the moment, I think lots of things are not quite clear yet, and already have a clearer view on the mechanistics would be great.
Thank you. Diego, I left you for last because you're kind of on the cutting edge of this bioinformatics work. So what would you like to see?
Yeah, I was thinking that there is this need that we are working all together here with the education and change of paradigm, because we need more hands from top and skilled bioinformaticians and modelers that can help us to improve all of these efforts that we are doing. I guess that with the, as Dr. Uwe just mentioned, in fields like cancer or in obesity, there is a way that people can also help and grant it easily, more easy. But in the field of creatine research, there is still this like barrier or people who is like not convinced. So I guess that the educational part will be a good thing. And in this case, for CREAS, for example, this project that we are launching and working on now, you can visit all creas.pro with C, like just as the root in Greek, but with C. And in there, you will find some bioinformatics data, some scientometrics, some also bibliometrics analysis that maybe can help us also to all know what are we working all together, in which group, maybe just to join efforts and also to have the this transparency and more accurate documentation to standardize, as we were talking, Doc, with the reports of, for example, adverse events or the type of the creatine that they are using. So all of that kind of stuff will help a lot. And so you are welcome to visit creas.pro, and we will continue just updating that with the support of everyone.
So the CREAS, CREAS.pro has got the beginning of this bioinformatics for creatine. Fascinating website already. But the goal is, after the conference is over, not only have availability of that bioinformatics application, but also a list of all the clinical trials that have been done where you can do searchable information on all the folks who are younger or older, or different diseases have been studied, and the dosages and all those type of things, as well as the safety data. And so we're trying to put this out so people can see it, add to it, and then instead of we all having to go find all this stuff ourselves, it's easy, accessible, so we can advance the field for that. So thank you very much.